Welcome back to the deep dive. Today, we're tackling a really complex topic, but it's absolutely vital. Cellular regulation in pediatric nursing.
Yeah, we're digging into hematologic disorders,
Yeah.
blood and clotting, and also neoplastic disorders, so cancer in kids.
It's definitely high-stakes stuff. Our aim here is to really zero in on the clinical priorities, give you the core concepts quickly and clearly.
And these concepts, cell replication, growth, proliferation,
Yeah.
they're just fundamental. And, while the diagnoses are tough, there's actually a lot of hope here.
Right.
I mean, cancer is still the leading cause of death from disease in children over 1 year old, which is sobering. But the 5-year survival rate now, it's climbed to an amazing 80%.
That's incredible. And it really underscores why getting a handle on these mechanisms is so important for nurses.
Exactly.
So our mission today is to kind of synthesize all this complex information, make it really practical. We'll start with the basics, the physiology, how kids are different, and then move straight into the really key nursing assessments and interventions.
Okay, so the hematologic system. We could go deep into the basics, but let's focus on what's different in kids. We know the main cells, RBCs, platelets, WBCs, they all come from those multipotent stem cells.
But it's that first year of life where things are really changing, right? Especially with red blood cells. That shift from fetal hemoglobin, HGBF, to the adult type, HGBA, that happens around 6 months.
Precisely. And that's a really key difference because HGBF it has a much shorter lifespan than HGBA. So until that adult hemoglobin takes over, the baby is just naturally at a higher risk for anemia, which leads right into what we call physiological anemia.
Right.
You typically see that between 2 and 6 months old.
And that's kind of a double hit, isn't it? The baby's growing super fast, using up iron,
Yep.
and the HGBF is dying off. Plus, the iron stores they got from mom usually run out around 4 to 6 months, too.
Exactly right. And here's a critical point for practice. Preterm infants. They're at an even higher risk.
Because they missed that last bit of iron transfer.
Exactly. They just didn't get those final crucial weeks of iron transfer across the placenta. So they start with less in the bank, so to speak.
Okay, that makes sense. Now, shifting gears a bit to cancer, let's unpack the big differences between childhood and adult cancers. The source material points this out clearly, like in comparison chart 24.1.
Yeah, the cell of origin is really the defining factor. Adult cancers, mostly carcinomas, starting in epithelial cells. Childhood cancers, though, they usually come from these primitive embryonal tissues, mesodermal tissues. So think blood cells like leukemia, bone sarcomas, CNS tumors. Very different starting points.
It's interesting, though, there's a bit of a paradox. The text says childhood cancers often respond better to treatment.
Generally, yes.
But metastasis, spreading, is often already there when they're diagnosed. How does that work? If it's already spread, why the good survival rate, that 80%? What makes these primitive tumors more responsive?
It's largely because they are so primitive and fast-growing that rapid growth actually makes them more vulnerable to chemo and radiation, which target rapidly dividing cells.
Okay.
It's different from the slower-growing, more differentiated cancers you often see in adults. And the warning signs in kids often tie back to the blood production itself, like pallor, fatigue, easy bruising.
Or the tumor just pressing on things.
Exactly. Compression causing things like bone pain or neurological symptoms. So if those subtle changes are the red flags, nurses need to be really sharp with their assessment. The signs of these disorders in kids can be really insidious, almost creeping up until they suddenly seem overwhelming.
Yeah, I was struck by how specific some signs are, like that early morning headache with vomiting. Is that really a strong indicator for a brain tumor? It sounds like something you absolutely cannot miss.
It's a huge red flag.
Yeah.
Needs immediate investigation. But other things too, just general lethargy that doesn't make sense, recurrent low fevers, unexplained bone pain, those are all high priority alerts as well.
Got it.
And then during the physical exam, you're looking for those outward signs of chronic issues, like spoon-shaped nails, that concavity, highly suggestive of iron deficiency. Clubbing of the fingers points right towards chronic low oxygen. And you've got to palpate for an enlarged liver or spleen, check the lymph nodes, are they non-tender, firm? That could suggest lymphoma sometimes.
So if the assessment raises concerns, the labs are where we look next. The CBC, the hemogram, that's foundational.
Absolutely.
But it sounds like just looking at the main counts, RBCs, WBCs, platelets, isn't always enough. The RBC indices are where the diagnostic clues often hide.
That's exactly right. We really zero in on those indices.
Yeah.
What's the NCV, the mean corpuscular volume, telling us? Is the cell microcytic, small? That often points to iron deficiency. Or is it macrocytic, large?
Okay.
And the MCHC, mean corpuscular hemoglobin concentration, is the cell hypochromic,
Mm,
meaning pale, less red. And the crucial thing always is that normal values depend entirely on the child's age. You can't use adult norms.
right. Age-dependent norms. Critical point.
Beyond the physical, though, the psychosocial impact is just immense, isn't it?
Oh, huge. Especially with something chronic like cancer. Isolation, missing school, and for teenagers trying to gain independence, this just throws a massive wrench into that whole developmental process.
It really does. And that's why this concept of pediatric assent is so important. It's in box 24.1 in the text. It's not just, getting a signature.
Right.
It's about truly helping older kids and adolescents understand their illness, what the treatment involves, what to expect. And we have to genuinely ask for their willingness to go along with it, their assent, making sure there isn't undue pressure. It's about respecting their developing autonomy.
Okay, let's dive into managing some common disorders, starting with iron deficiency anemia, IDA, often dietary and toddlers, right? Like too much cow's milk.
Yeah, that's a classic cause. More than 24 ounces of cow's milk a day can interfere with iron absorption and displace iron-rich foods, or just not enough iron in the diet overall.
And management is usually oral iron supplements, like ferrous sulfate.
Typically, yes. And for nursing, it's a lot about education and safety. That liquid iron stains teeth badly, so teach parents to use a straw or dropper way back in the mouth.
Good tip.
It also commonly causes constipation, so families need a heads up on managing that mess. And this is really important. Iron supplements are a leading cause of accidental poisoning in young kids. They must be stored safely out of reach.
Okay, critical safety point.
Yeah.
Now, if we see that hypochromic microcytic anemia, but it doesn't seem to be iron deficiency, lead poisoning has to be on the radar.
Immediately. Lead directly messes with the body's ability to make hemoglobin, which is essential for hemoglobin.
And the treatment is chelation therapy.
Right, to bind and remove the heavy metals. Nursing care during chelation really focuses on making sure the child stays well hydrated. And of course, following all the screening guidelines for lead exposure risk at different ages.
Okay. Moving on to inherited disorders. Sickle cell disease, SCD, that's a major area.
Huge, yeah. So abnormal hemoglobin S replaces the normal hemoglobin A. And then stressors like infection, dehydration, low oxygen cause the red cells to change into that sickle shape.
Leading to blockages.
Exactly. Vaso-occlusion. That blocks blood flow, causes tissue hypoxia, and leads to absolutely excruciating pain. That's the hallmark of a vaso-occlusive episode or crisis.
So managing those episodes, what are the absolute priorities?
Three main things. Number one, pain control. Often need scheduled opioids, not just PRN, especially initially. Get ahead of the pain.
Okay.
Number two, hydration. Aggressive hydration. We're talking 150 milliliter per kilo per day, or basically double their usual maintenance fluids. Flush the system.
Double maintenance, wow.
And number three, this is key. Oxygen. Only give supplemental oxygen if their O2 saturation is actually below 92%.
Why only then?
Because giving oxygen when they're not hypoxic can actually suppress the bone marrow's drive to make new red blood cells. So only if needed based on SATs.
Got it. That's a crucial distinction. And preventative measures are big too, right? Penicillin, vaccines.
Absolutely. Prophylactic penicillin daily until age 5 is standard to prevent pneumococcal infections. And they need all their regular vaccines, plus extras like pneumococcal, meningococcal, and the annual flu shot. And one more pain point, the source specifically warns against using meperidine, Demerol.
Why is that?
Higher risk of seizures associated with its metabolite, especially with repeated doses. So avoid meperidine.
Okay. Another serious hemoglobin issue is beta-thalassemia major.
Right. Here, the beta-globin chain of hemoglobin is reduced or absent. This causes severe anemia, requiring chronic blood transfusions just for survival.
And the big complication there is iron overload.
Exactly. From the hemolysis itself and all those transfusions, it's called hemosiderosis. So lifelong chelation therapy using drugs like deferoxamine or newer oral agents is absolutely essential to remove that excess iron and allow for longer survival.
Makes sense. And finally, for clotting disorders, Hemophilia A is the most common. Factor VIII deficiency, X-linked.
Yep. So management is really focused on preventing bleeds, teaching families to avoid high-contact sports. Things like swimming, running, tennis are usually much better choices.
And if a bleed does happen,
Factor VIII replacement is the key, given as a slow 5E push. And it's vital to meticulously document the lot numbers of the factor product used. For joint bleeds, standard rice rest, ice, compression, elevation helps manage the acute phase. And teaching home infusion empowers parents and teens to treat bleeds quickly.
All right, let's pivot fully into oncology. Leukemia is the most common childhood cancer. All acute lymphoblastic leukemia treatment seems very structured. Phases like induction, consolidation.
That's right. Induction aims for remission, consolidation strengthens it, maintenance keeps it going, and CNS prophylaxis treats or prevents leukemia in the spinal fluid. It's a long road, often 2 to 3 years.
And for kids with IL or AML, acute myelogenous leukemia needing blood transfusions, there's a really specific safety protocol mentioned.
Yes, this is non-negotiable. All blood products pack red cells, platelets must be irradiated, CMV negative, and lutodepleted.
Why all three?
Irradiation prevents transfusion-associated graft versus host disease, where donor lymphocytes attack the recipient. CMV negative prevents cytomegalovirus transmission, which is dangerous for immunosuppressed patients. And leukodepletion removes white blood cells, reducing the risk of reactions and antibody formation, which is critical if they might need a stem cell transplant later.
Okay, that makes sense. Let's talk managing side effects of chemo and radiation. Neutropenia. That sounds like the biggest infection risk. How do we actually figure out that critical number, the ANC?
The absolute neutrophil count, yeah.
Mm.
It's pretty straightforward math, but critical. You take the percentage of bands, which are immature neutrophils, and the percentage of segs, mature neutrophils,
Okay.
and multiply that sum by the total white blood cell count. That gives you the ANC.
And the danger zone is below 500?
Below 500 is severe neutropenia, critically immunocompromised. Any fever, even a low-grade one, in a child with an ANC under 500 is considered a medical emergency. Needs immediate evaluation and broad-spectrum IV antibiotics, usually within the hour, to prevent life-threatening sepsis.
Wow, okay. Another risk is extravasation chemo, leaking out of the vein. Certain drugs seem particularly bad, like cisplatin, miclorethimine. Why are those specific ones so dangerous?
Those are vesicants. That means if they leak into the surrounding tissue, they cause immediate and severe tissue damage. Blistering, necrosis, sloughing. It can be devastating.
Prevention is key.
Absolutely. Requires meticulous 5E site assessment, good blood return checks, and often using central venous access devices for vesicant administration is much safer.
Okay. For the more common side effects like nausea and vomiting, aggressive treatment is the way to go.
Definitely. Pre-medicate before chemo with antiemetics. Often need around-the-clock dosing initially, not just PRN. And the text even mentions things like ginger or maybe foot massage as complementary therapies that might help some kids.
And radiation skincare, what's the main advice there?
Gentle care is the theme. Gentle cleansing, pat dry, no rubbing. Avoid sun exposure completely on the treated area. No heat, no cold packs. And crucially, use a high SPF sunscreen on that skin for at least 8 weeks after treatment finishes because it stays incredibly sensitive to sunlight.
Got it. Brain tumors, most common solid tumor in kids. We mentioned the signs often relate to increased intracranial pressure, like that morning headache and vomiting.
Yep. And pre-op and post-op care is all about stabilizing their neurostatus. Often involves giving dexamethasone, a steroid, to decrease brain swelling, close ICP monitoring, and positioning is critical. Follow the surgeon's orders exactly. Usually head midline, HOB flat, or at a specific prescribed level. Side positioning is often preferred over supine.
And the major red flag.
A fixed and dilated pupil that indicates severe pressure, potentially herniation, is an absolute neurosurgical emergency. Call for help immediately.
Okay. And then Wilms tumor, nephroblastoma, most common kidney tumor.
Yes. And this comes with perhaps the single most important procedural warning in all of pediatric oncology nursing. Do not palpate the abdomen unnecessarily after the tumor is suspected or diagnosed before surgery.
Why is that so critical?
Because the tumor is often soft, encapsulated.
Mhm.
Palpating it, especially vigorously, can rupture that capsule, spilling tumor cells into the abdomen, seeding metastasis. It dramatically worsens the prognosis. So, assess once gently if needed for diagnosis, then signs up, hands off, protect that tumor integrity.
Wow. Okay, absolutely vital point. To wrap up the clinical focus, let's quickly touch on preventative health for adolescents, kind of bridging into anticipatory guidance.
Right. Important transition. For young men, we need to be teaching and encouraging a monthly testicular self-examination, TSE. Testicular cancer is highly curable, especially when caught early.
And for young women.
Promote the HPV vaccine, which prevents the strains of HPV most likely to cause cervical cancer. And ensure sexually active adolescents start getting pap smears for cervical cancer screening, usually recommended within about 3 years of becoming sexually active. #outro.
Okay, wow. We have covered a massive amount of really critical, potentially life-saving information today.
We definitely moved quickly.
Yeah, from understanding that HDBF vulnerability early on to the specific rules for sickle cell management pain, hydration, when to give oxygen right through to that absolute do not touch warning for Wilms tumor.
I think the core takeaway is always prioritizing those high-stakes interventions, like calculating the ANC right, ensuring blood product safety while keeping that constant vigilance for the early, often subtle signs of these disorders.
Definitely. So let's leave our listeners with a final thought. With all this focus on acute care managing crises, when we're dealing with chronic illness or cancer in a child, what's the ultimate goal for their overall well-being and development?
That's a great question. I think it really boils down to maintaining, as much as humanly possible, a near normal life for that child.
You're normal.
Yeah. The goal of all our expert nursing care, all the treatments, is really to minimize the illness's disruption. That means pushing for school attendance when they're well enough, supporting age-appropriate activities. Maybe it's adaptive sports for a teen who's had a kidney removed, or finding safe ways for a child with hemophilia to be active, like swimming. It's about managing the disease so the child can still achieve their developmental milestones, learn to cope, and just grow up.
That's a perfect perspective to keep front and center. Manage the illness so the child can live their life. Excellent. Well, thank you for digging deep with us today.
My pleasure.
And thank you, our listeners, for being well informed with us. Thank you for being a part of our little last-minute lecture family.